Good morning, all, and it's a pleasure to chair this session. And the first speaker here, I invite Dr. Madhuri Patil to talk on fertility preservation in young cancer survivors. Dr. Madhuri Patil is a core academician, doesn't require any introduction as such. Please go ahead, ma'am.
Thank you, Sonal, for that introduction, and I thank ISAR 2024 for giving me this opportunity. So today, I would be talking on fertility preservation in young cancer survivors. So this would be the outline of my talk as to why fertility preservation is required, what is the effect of the uh, cancer or its treatment on fertility, and what are the issues that we need to consider before we recommend fertility preservation, and what is the outcome. So why do we require fertility preservation? We know that there is increase in the incidence of cancer during the reproductive age, and the majority of the young patients diagnosed with cancer will become long-time survivors due to improved survival and cure rates of cancer. And many of the survivors will become infertile due to their treatment. And the ability to start the family and have children is the key quality in the life issues in cancer survivors. So when we look at the risk of infertility with different cancers, we can see the cancer itself has a highest risk when there's going to be a total body irradiation, either to the pelvis or testis, and the chemotherapy is given before bone marrow transfer. And it has also been seen that metastatic Ewing's carcinoma and Hodgkin's lymphoma have a very high risk of infertility. Whereas acute lymphocytic leukemia, Wilms tumor, brain tumor, surgery, or radiotherapy, soft tissue sarcomas, Hodgkin's lymphoma, which is of low stage, have low risk. Whereas acute myeloid leukemia, osteosarcoma, Ewing sarcoma, and neuroblastomas and non-Hodgkin's lymphoma, brain tumors, and when RT used is more than 24 gari, or Hodgkin's lymphoma of high stage have a medium risk. So how does cancer affect fertility in the males? So we will divide our talk into males and the females. So basically in the males, it is via the endocrine and nutritional alterations. There's induction of a hypermetabolic state whereby the tumor cells, due to their rapid proliferation and apoptosis, produce large quantities of spermatotoxic metabolites. Stress following cancer or its treatment can result in hormonal alterations that have deleterious effects on the sperm production as well as function. Malignancy that involves deficiencies in vitamins, minerals, and trace elements, which play a critical role in the maintenance of spermatogenic quality. The tumors may also promote an autoimmune response by producing anti-sperm antibodies, preventing sperm motility, or by releasing cytokines, leading to germ cell and Leydig cell injury. Fever, usually associated with Hodgkin's disease, negatively affects the sperm parameters, and Hodgkin's disease and germ cell tumors produce direct gonadotoxic effects. It has also been seen that certain cancers like leukemia, testicular cancer, and Hodgkin's disease affect the sperm parameters even before anti-cancer treatment. Leukemia can affect the endocrine system and the hormones that regulate spermatogenesis, which include FSH, LH, testosterone, and inhibin B, which result in impairment of spermatogenesis. And patients with lymphoma had significantly impaired pre-freeze and post-thaw sperm quality, whereas patients with non-Hodgkin's lymphoma had spermatozoa of higher quality than that with Hodgkin's disease, and there was no difference found in the clinical or hormonal parameters when these two conditions were compared. So if you look at the effect, you can see that low sperm count is seen in leukemia, as well as in chronic myeloid leukemia. Sperm motility is affected in all the three. Abnormal morphology basically is seen in chronic myeloid leukemia. Low post-thaw quality is seen in almost all conditions, whereas endocrine changes are also seen in almost all of them. And infiltration into the testes is seen in acute lymphocytic leukemia as well as chronic myeloid leukemia. The testicular tumors can also impair fertility by disturbing spermatogenesis by destruction of surrounding tissue, local secretion of HCG and other paracrine factors, intrascrotal temperature elevation, and alteration in the local blood flow. The tumor-derived vasculogenesis, in which malignant cells rise to the endothelial cells, can also decrease the sperm count. And in many patients, especially those who have a congenital cryptorchism, can result in development of carcinoma in situ. The surgery done for testicular tumors can also affect, and it has been seen that after orchidectomy, there's 50% decrease in the sperm concentration during first few months, and 10% patients become azoospermic after unilateral. It is also seen that when retroperitoneal lymph node dissection is done together with the radical orchidectomy, it can again result in fertility damage due to injury to the adjacent sympathetic ganglia, which are responsible for emission and ejaculation that can cause an ejaculation. Coming to the female, we know that cancer can also affect the ovarian reserve, and it has been seen that patients with lymphoma have diminished ovarian reserve as well as ovarian response, and infertility after cancer diagnosis occurred more frequently in survivors of PCOS than the survivors of those who did not have PCOS. We also know that breast cancer has an effect on the ovarian reserve, and it has been seen that basically in a normal a patient who does not have any BRCA mutation, there's not much alteration in the ovarian reserve. But those patients who do have BRCA mutation, there is definitely a low ovarian reserve as well as there is a low response. In older breast cancer patients, the ovarian reserve may be adversely affected as against not being affected in young patients. And here we can clearly see that in BRCA positive, the ovarian reserve is definitely affected in those who are more than 35 years, and both in the BRCA positive as well as negative group. Coming to the effect of radiotherapy and chemotherapy on the gonads, and this basically depends upon the age of the patient, the medication used, the radiation field, and the dose of radiation that has been used. And after treatment in the male, one could have oligospermia or azoospermia, whereas in the female, we could have irregular menstrual cycles, premature ovarian failure, or infertility. Radiotherapy basically kills cancer cells by damaging DNA directly or creating charged particles, which can also damage the normal cells, and therefore pelvic radiotherapy can result in acute ovarian failure and premature menopause and also affect the endometrium. The late side effects on the ovaries include atrophy and fibrosis with thick hyaline arterioles and venules, whereas cranial radiotherapy can disrupt the function of the hypothalamo-pituitary axis. And here we can see the gonadotoxicity of the dose. So it is very high if the exposure is more than 10 gray, and it is low if the exposure is less than 6 gray. The effect of radiotherapy will also depend upon the radiation scatter, the interaction with the matter and biological diffusion, dose beyond the field borders, and also movement during the therapy. When we talk about the male, we can see that there could be damage to the spermatogonal stem cells with permanent azoospermia, to the differentiating germ cells where there's only transient azoospermia, whereas when there's damage to the Sertoli cell, we could have either transient or permanent azoospermia. Though damage to the Leydig cells is very less, but it can occur in very high doses, resulting in testosterone deficiency. Whereas in the female, basically the damage is mostly to the primordial follicles, and this will basically depend upon the ovarian location, the radiation field, scattered radiation, and what was the amount of dose that has been given, the age of the patient, the oocyte pole, as well as the radiation dose and the total dose, as well as the fractionation schedule. So you can see over here clearly that as the age increases, the amount of radiation exposure required to result in ovarian failure keeps on decreasing. And the risk of premature ovarian failure is only about 4 times in adolescent as compared to 24 times in a woman in a reproductive age group. The late side effects on the ovaries are atrophy and fibrosis with thick hyaline arterioles and venules. And here we can clearly again see that as the age increases, the radiation dose decreases, which results in premature ovarian failure. We also need to consider the effect of radiation on the uterus, and especially this happens when the exposure is to the abdomen, pelvis, or when the total body irradiation is given. And this can basically result in decreased uterine volume in young girls and adolescent girls. It can disrupt the receptivity and pregnancy maintenance, resulting in recurrent miscarriages and preterm deliveries, IUGR, and placental abnormalities. And it can also then have menstrual problems. It can disrupt the uterine anatomy, diminish the muscular elasticity and contractility, increase myometrial fibrosis, and reduce uterine volume. It can also result in vascular damage, endometrial injury, cervical incompetence due to atrophy, and cervical stenosis and fibrosis. The prepubertal uterus actually is more vulnerable to the radiotherapy dose. The cranial irradiation can also disturb the hypothalamo-hypophyseal axis, which can result in early or delayed puberty with premature ovarian failure. There could be decreased levels of FSH, LH, and estradiol, which require treatment with gonadotrophins. And usually, ovarian damage may also be present with low fertility rates. The radioactive ion therapy used for hypothyroidism can also result in temporary amenorrhea and oligomenorrhea lasting for about 4 to 10 months, and it occurs in about 20 to 27% of menstruating women who are being given this therapy. We know that we have 4 types of chemotherapeutic agents. We have the alkylating, the antimetabolites, the platinum, as well as the taxanes. And you can clearly see the risk of infertility with all these agents could either be high, medium, or low. And I will discuss that in the males and the females. So basically, the chemotherapy can result in short-term and long-term genetic damage, which results basically in oxidative stress with apoptosis of spermatogonia and spermatogonial stem cells with gene mutations, chromosomal breakage, and sperm aneuploidy. It can also result in long-term somatic cell damage with damage to the Sertoli as well as Leydig cells with decreased spermatogenesis and testicular volume. And there could be long-term stromal damage with interstitial fibrosis and reduced blood flow. And here you can clearly see that most of the alkylating agents have either a high or an intermediate risk. The antimetabolites and antimitotic cytostatics have a very low risk of infertility in men. And when we take into anti-tumor antibodies, except for dactinomycin, all of them have a low risk. And when we talk about the combination, only ABVD and CHOP have a low risk, whereas all the others, they have a high risk of spermatogenic failure. Coming to the female, it can result in follicular apoptosis, and it can also affect the recruitment and apoptosis of primordial follicles. And this can then result in reduction of the primordial follicular reserve as well as loss of growth inhibition because of excessive activation. There could also be vascular injury, stromal damage, and inflammation with decreased angiogenesis and fibrosis. And this direct DNA damage results in destruction of growing follicles with lesser production of AMH, and thus there is less suppression of the growth activation with increased recruitment of primordial follicles, which results in the follicular burnout. And the damage to the ovarian stroma and blood vessels can also result in impaired steroidogenesis. And this gonadal damage basically is related to age, and it increases as the age increases, and also as the dose and the treatment duration increases. And this is more when there is combination of treatment of both radio and chemotherapy, and with alkylating agents it is maximum. And basically the effect is basically because of vascular damage or a DNA damage which is being seen. And if you see, alkylating agents are the most toxic, whereas the antimetabolites and antimitotic cytotoxic as well as anti-tumor antibiotics have a low toxicity. And when you talk about the platinum-based drugs, if you use in higher doses, it's there is a high risk of ovarian failure. And if it is used in lesser dose, it is intermediate. Whereas combination therapies have either a high, intermediate, and low risk depending upon the age of the patient. And it has been seen, infertility is seen in about 40% of the cases. Probability of early menopause is 25% at the age of 30 years. And amenorrhea basically is seen in about 90% if the age is more than 40, and anywhere between 20 to 90% in younger patients. So the other anti-cancer treatments like targeted monoclonal and tyrosine kinase have lesser effect on on the follicular pool. And you can also see that there are other newer drugs which are there. Their effect is basically not known. And when we talk about immunotherapy, there is very little data, and the endocrine immune-related adverse events such as hypothyroidism or hypophysitis can then result in ovarian insufficiency by reducing the gonadotropin secretion. So we have to therefore assess the fertility risk, and this can be done by clinical and lab parameters and certain extrinsic factors like the nature of predicted treatment, whether it's high, low, or medium risk, the practicalities, as well as time, expertise, and funding that is available. One should remember that resumption of menstruation post-chemotherapy does not mean that fertility has been reduced. We also know that sexual dysfunction is an important side effect of cancer treatment, and basically it could be involved due to the treatment to the tumor itself, especially when they have pelvic malignancies, and also when multimodal treatment, which involves chemotherapy and radiotherapy and hematopoietic cell transplant, can increase the sexual dysfunction, wherein you could have loss of sexual desire or arousal. There could be orgasmic difficulties, and also dyspareunia, steaming from vaginal dryness, insufficient lubrication, atrophy, and stenosis. And therefore, effectively addressing sexual dysfunction can be difficult given the varied etiologies and multifactorial nature of these problems. We need to address certain things before we advise fertility preservation, and this includes the oncological prognosis and quality of life, fertility and obstetric history and potential, availability and reliability of the fertility preservation technologies, the surgical modalities and expertise, medical and laboratory modalities, explaining the meaning of success, psychosocial perspective, parent counseling, and obtaining informal consent. In the male, we know in adults, sperm cryopreservation is an established technique, whereas testicular sperm extraction and testicular tissue freezing is still experimental. Hormonal therapy is not indicated. In children, most of the therapies are experimental, and we have no other option other than testicular tissue freezing. Whereas in the female, in the pre-pubertal, it is ovarian tissue freezing, whereas in the post-pubertal, we could either have ovarian tissue freezing, immature oocyte freezing, or ovarian stimulation with oocyte or embryo freezing. We could also go for ovariopexy during pelvic irradiation, GnRH agonist before, and with chemotherapy and fertility sparing surgeries in early stages of cancer. These are the various treatments can be done when there is gynecological cancer, when they're exposed to radiation therapy, wherein the options are given up here. And if you look at the reproductive outcome, it has been seen that many a times there is recovery of spermatogenesis, and basically after radiotherapy, when the dose of exposure is 0.2 gyri, it happens in 6 months, but if the exposure is higher, it will almost take 9 to 18 months. Many a times there could be complete destruction if the exposure is more, and after a high dose of cyclophosphamide, sperm recovery may take place after 1 year. And in the females, I just have 2 slides. I'll just finish. So in the female, basically, depending upon the age, AMH, we can allocate points. And depending upon the points, we get the odds ratio of what would be the ovarian reserve post-treatment. And when we look at the safety, it has been seen that there's no detectable increased risk and disease recurrence. And the cancer treatment has mutagenic effects on the oocytes present in the growing follicles, and risk is related to the stage of the oocyte development during the exposure and the drug treatment which has been used. But it has also been seen in several papers and reported that it does not increase the risk of cancer, chromosomal abnormalities, congenital abnormalities, or fetal malformations in the offspring if conception happens 1 year later. So basically, I would end with the following points, that there are several challenges in making the decision and navigation of these decisions, and therefore increasing the knowledge satisfaction will be helpful in decision making to decrease the decisional conflicts and decisional regrets. A collaboration among reproductive physicians, biologists, endocrinologists, oncologists, surgeons, psychologists, and gynecologists is necessary to ensure the best fertility preservation treatment. And basically, once cancer is diagnosed, depending on the treatment plan, one must refer the patient to the fertility preservation consultant. And depending on the various factors, either we do the fertility preservation procedures or give a expected management and then start the cancer treatment. And therefore, the recommendations for fertility preservation are that oncology clinicians must focus not only on the goal of eradicating disease, but also on mitigating the long-term effect of treatment. We need to discuss fertility preservation with all patients if infertility is a potential risk of disease or its therapy, and address it as early as possible, even before the treatment starts. Refer interested patients to the reproductive medicine specialist, and one needs to prevent, diagnose, and treat sexual concerns throughout the course of cancer treatment, as well as survivorship, which is very important and neglected at many times. I thank you all for a patient hearing.
Thank you, ma'am, for those for the very elaborate description of effects of various cancer treatments and fertility preservation modalities. We will have questions at the end of the session, ma'am. Thank you very much for your presentation.